and really looking forward to a robust discussion of some timely topics um, facing our healthcare system here in Massachusetts. It's great to see everyone, and I really, as always, appreciate your time and your commitment to working with and helping to advise the Health Policy Commission as we continue our important work. Since this is the first meeting of the year of 2025, first wanted to just reintroduce the advisory council members, welcome a few new members, and just talk a little bit about what our plan for this year is with the advisory council. So to welcome everyone and to orient everyone, I'm going to turn it over to Deputy Executive Director Colleen Elstmeyer.
Great. Thanks so much, David. Welcome, everyone. Welcome back and welcome to a few new faces here today. So yes, as David indicated, we decided that in light of the new responsibilities and the new work entrusted to the HPC and the legislation passed by the legislature and signed by the governor earlier this year, which we will be discussing today, we invited almost entirely the membership back to serve until the new laws take effect. So welcome back. Thank you. This is a critically important sounding board for the HPC, and we're seriously very grateful for you all taking the time to join us today and whenever we have advisory council meetings. So the membership is here on this slide. I did want to welcome a few new faces to the advisory council. We have Roland Goff from the Massachusetts Nurses Association. Roland is taking over for Julie Pinkham, one of our original advisory council members. We have Dr. Barbara Spivak from the Mass Medical Society, who's taking over for Dr. Ron Dunlap, who is also with us for many, many years. We have Harry Weissman from the Disability Policy Consortium, who I actually saw on our local news last night, talking about how our icy sidewalks pose challenges for our residents with disabilities and mobility issues. So shout out to Harry, you did a great job. And then we have Stephen Wynn from the Behavioral Health Network, who's joining us for the first time. And Erica Wilkinson is also taking over for Mike Keljo, who you all know is the new commissioner of the Division of Insurance. So welcome again, welcome to you all, welcome back. We're so deeply appreciative. Thank you for serving on this extended term through the end of June 2025. Thank you for supporting us in our development and implementation of these new expanded work streams. It's a really exciting time for the HPC, so we're really grateful. All right, any questions or back to you, David Seltz.
Sounds great. Thank you, Colleen. And just to build off of what Colleen said, given some of the changes that are going to be happening with both the HPC board later this year and the new responsibilities, we do expect to reconvene an advisory council in the second half of this year, and want to be able to make sure that we can best reflect all of the new responsibilities and new opportunities to provide the HPC Council. But really am appreciative, as Colleen said, to have this extended term for this advisory council to help us as we think through the initial implementation of these new laws. So thank you. Just to dive right into today's agenda, we had a couple of things that we hoped to engage in a discussion with you about today. First, I'll tee this conversation up, but want to talk about some of the very recent and extensive federal changes that have come down in the last month. Second, do want to share a brief summary for you of the new legislation that was passed and signed into law by the governor earlier this year, and the implications for the Health Policy Commission's work. Would love your advice and counsel as we begin implementation of some significant new and important responsibilities. And then finally, if we have time, just wanted to highlight some recent work that the HPC has done specifically on primary care access challenges, as we begin to set up a new task force, which will be looking at those issues in particular. So a lot on the agenda as always. And I'm going to just dive right into, I think, our first agenda item. You know, I felt it was important to begin here because I do suspect that the changes at the federal level are top of mind for many of you and many of the advisory council members and organizations. And the implications of these recent federal changes, specifically on healthcare policy. In the past month, there have been, I think, a rapid pace of announcements and orders with the potential for far-ranging impacts on Massachusetts healthcare providers, the healthcare workforce, health plans, the life sciences industry, academic institutions here in Massachusetts, biomedical research, and of course, ultimately on patients. I do want to recognize that there is and continues to be a significant amount of ongoing uncertainty with regard to legal interpretation and enforcement of many of these orders and directives. And in addition, there are numerous cases of judicial review and challenge, all of which is developing in real time. Like many of you, I get the New York Times push alerts, and there have been seemingly one every couple of hours over the past month. So for this first part of the conversation, we'd really like to hear from you about what you are seeing in terms of implications so far. What are the issues that you are closely tracking and monitoring, and potential areas of risk or concern or interest as these developments are occurring? You all represent a very broad range of interests and experts here in Massachusetts, and I think this is the perfect group to help counsel the HPC and state government more broadly about how we can track these changes, track the implications, and also to stay in close communication with all of you and discuss how we can continue to share information and identify areas for potential collaboration. So really hoping to hear from all of you on your perspective here. But to kick off the discussion, we've put together a few very high-level summary slides of some of the recent orders and directives that are most closely related to healthcare. And I should say at the top, as a huge disclaimer, this is not an exhaustive list. And we encourage you to please share if there are other issues or changes that you are tracking closely. I'm going to ask our Deputy General Counsel, Susan Flanagan Cahill, just to walk through at a high level what we have put together in terms of a summary of some of these recent changes. And finally, I think a fair warning to say that we are not in a position to provide legal interpretation of some of these orders, but very happy to hear from you if there are specific questions that specific open questions that you are considering and thinking about. So just to orient us and create that foundation, I'll turn it over to Susan to summarize some of those changes.
Great. Thank you, David, and good afternoon. And I appreciate all those disclaimers, David. Thank you. We have two slides that list many of the orders and directives pertaining to healthcare, but as David said, it's not an exhaustive list. So first, this slide here lists executive orders that the president has issued. And he has rescinded several Biden executive orders, including, as you see there in the slide, orders that had strengthened the Affordable Care Act and Medicaid, leading to expanded enrollment periods for ACA plans, extra funding for ACA navigators, and increased access to coverage. And also had directed CMMI to create new payment models that would lower prescription drug prices for Medicare and Medicaid enrollees and promote innovation. Other rescinded Biden executive orders include orders that supported protections for LGBTQI individuals, including access to medically necessary care, protected expanded access to abortion care, established a coordinated federal response to COVID-19 and other emerging biological and pandemic threats, and directed responsible deployment of AI tools in healthcare. And with these rescissions, the president has instructed federal agencies to take all necessary steps to revoke or amend actions that resulted from these rescinded orders. A few other President Trump executive orders include withdrawing the U.S. from the World Health Organization, directing federal agencies to terminate all DEIA programs and activities, directing federal agencies to recognize only two sexes, male and female, prohibiting the use of taxpayer dollars to fund or promote elective abortions, and establishing a policy that the federal government will not fund or otherwise support gender-affirming care for pediatric patients suffering from gender dysphoria. As David indicated, these executive orders do not by themselves change the law of the land or create or rescind regulations, but they signal the administration's intent and they guide and direct federal agency policy and other regulatory action. And on these the next slide, to that end, there have been several directives issued by various federal agencies in addition to these executive orders. As you can see here, the Office of Management and Budget issued a temporary pause on federal grants, loans, and other financial assistance programs, pending reviews to ensure alignment with these executive orders. OBM rescinded this directive, but there remains confusion about the current status. The National Institute of Health announced an immediate reduction of indirect rates for all NIH grants to 15%. A federal judge halted implementation of this reduction pending a court hearing that's scheduled later this month. The acting Secretary of Health and Human Services declared a pause on issuing documents, guidance, and any public communications unless approved by a presidential appointee. This directive took effect February 1st, but it's unclear today that these restrictions have been lifted. There's also a government-wide freeze on any rulemaking for 60 days. And finally, the Department of Homeland Security revoked a policy not to arrest people without legal residency at or near sensitive location, which includes hospitals. So again, it's not an exhaustive list, but we look forward to hearing your thoughts and having a discussion on these orders.
Thank you very much, Susan, and thank you for going through that. As I said, I do think it's important that we, as a community, share information and have an ability to discuss implications of these changes. So with that as kind of a background, I really do want to open it up and hear from members of the advisory council, which of these orders you have been tracking closely and monitoring, any implications that you have already identified for your organizations or the members your organizations directly serve, and just to provide us and the Health Policy Commission, and as I said, state government more broadly, with information so that we can appropriately understand the context of these changes as we pursue our mission and work. So thank you, Michael. I see you raise your hand and would love to have you kick off the conversation.
Thank you, David. Appreciate this overview of where you and the staff have seen some of the implications of some of these federal changes, executive orders, and directives. We in the health center community have a few different areas that we're tracking. One, of course, we fell into the area of the temporary pause, the freezes in funding, the federal funding. Many of our health centers across the state rely on their federal grant to fund their programs and services, to make payroll, to cover the cost for their staff. And unfortunately, that freeze, as you may have seen some national news, I think 2 health centers in Virginia temporarily had to close. As a result of the freeze, health centers here were also thinking about what that might look like if they went another week or 2 without pay. So we're watching the freeze to make sure that that doesn't become a reality again. We are also worried about the services we provide. As you all know, we provide gender affirming care, LGBTQIA services. We provide health equity programs, as health equity is under attack as well. We do, many of our health centers do anti-racism work, DEI, have DEI positions programs. And now there's probably a page and a half, David, and I'm sure you've seen it as well, of words that we can't say and that we need to scrub from our websites and our programs. I've said often that this is not about scrubbing words, this is about scrubbing programs. And that the ultimate objective of the federal government is to say, when you apply or update us, so when we do a site visit related to your program, we're going to ask you, do you do these services? So words are not the target, though people think scrubbing words is similar to what they're doing with the federal staff. They're saying, help us identify where these programs exist, and you can't hide them. You can't rename them. They've told federal staff this. They will eventually tell federal grantees the same thing. So I do think this is a threat. We are deeply concerned because we remain committed to our LGBTQ, trans health, harm reduction, reentry, health equity communities. And we want to maintain that. We know we're in Massachusetts and we have a different moral compass here about these services, but we are concerned. Last but not least, I think we know that there are implications with the federal match, that if they cut back on that match, the state might be forced to do some readjustments around what it covers, and we are deeply concerned about that as well. So David, I hope that helps to the conversation.
Absolutely. Thank you, Michael. And thank you for sharing your thoughts there. I will share that with that initial temporary pause of federal grants and loans, I, like many, thought of our strong community health center network and how much there is a reliance on federal funding to support that network through HRSA and through other mechanisms. So it's interesting to hear that even a short-term disruption in terms of that funding can have pretty immediate implications. So please keep us informed if there are changes there that you're noticing and seeing. Thank you. Eric Oko, please. Would love to hear your thoughts and perspective.
Thank you. So I'm a benefits broker, as you know. I represent the other benefit brokers in the state. We represent employers, large and small, and their employees. So I thought I'd just share that perspective.
Thank you.
Initially, I'm hearing anxiety and trepidation about people losing coverage in their health plans. And so while employee benefits are subject to all sorts of federal regulations, we've had to explain to people that there's a strong state oversight, in particular over insurance with a capital I. And so because the state has governance over insurance matters, the state has a lot of opportunity to protect its values that it holds dear. And so when there's questions about abortion coverage, gender affirming care coverage, and other coverages, we're trying to counsel people to not panic. Nothing has changed overnight in terms of their coverage. I'll defer to the insurance carriers on the call here to talk about it further, but we haven't seen that sort of impact yet. It doesn't mean that providers won't be impacted indirectly. Employees in other states might have trouble getting the care they want in that particular state. But there are some protections in Massachusetts here because we govern insurance and have our own state mandates that at least apply to fully insured plans. And the last thing I'll say is we're getting an increased call for behavioral health support, mental health support. How do you process all these things? And so other ways that employers can offer that support to its employees is something we keep hearing about. Thank you.
Thank you, Eric. And have you heard it? You know, are you still serving on the Connector Authority Board?
Yes, but I'm going to let Audrey speak to that one. but go ahead. What's your
No,
question?
I understand. And thinking about what the intersection of state rulemaking here, state authority versus federal authority, especially in our insurance market where that it is divided, I think is important, and I appreciate you continuing to share that message, and we'll share some of this with our friends at the Division of Insurance as well. Lizette, would love to hear from you. I see you next. Hi.
Hi, thanks. I represent community health workers, of which there are about 6,000 in Massachusetts. And the main concern is people, their clients, patients not showing up for appointments, not only for medical care, but also for social service care. And not showing up, not only, mostly, not because they are of their own legal status, or the patients, but fear that they will compromise their families or relatives or housemates whose legal status may not be as clear. The second piece is the fear of losing their jobs. Kind of, it doesn't take a genius to know that a service that's still not reimbursable will be the first in the chopping block. So people, community health workers are very aware about the potential of, losing their incomes. And the third one is a generalized demoralization, feeling low, feeling attacked, feeling that a lot of this aggression is directed to them as women of color, as people that are not necessarily affluent. So just a heads up, I mean, those three are very serious things. This is what we know preliminary. But in response to the many concerns that we hear, we are launching on the 28th what we're calling affirmative listening sessions. And the idea is to bring community health workers to tell us exactly what you're asking. What are you seeing? What do you hear? And what kind of resources or supports do we need from your professional association? We're going to do those monthly. I can predict some of the things that will come up, but I'm sure that there will be things that we have no idea about. So more to come.
Thank you so much, and please be in touch with us after you've kicked off those affirmative listening sessions. I think it will be really helpful for us to be able to learn what you're learning, and certainly when I think of the community health worker workforce, that's a population that is really connected to the communities, connected to residents and patients, across Massachusetts, really kind of at the front lines of being able to hear and see some of these impacts. And so I think that the perspective of this workforce in particular will be really helpful as we move forward. And just to build off of what you said, would also advisory council members encourage you also to share, anything that you are doing within your own organizations, talking to your workforce, and what you're hearing. That's all very helpful as well. David Mariotto, would love to hear from you.
Thank you, David, and appreciate this, and I'll be brief. From the inpatient behavioral health world, picking up on what Lizette just said, we're very concerned with people not showing up for care or leaving the facility early. This is anecdotal. It's recent, obviously. But for example, one of my hospitals was telling me last week that they had two kids. The family came and got them in the unit, in the psychiatric unit, before they were ready to go, because they were afraid something was going to happen. Someone was going to go in and get the kids or something to that effect. So we're also concerned with people not showing up even to get admitted when they need help. So we're watching the immigrant issue very closely and going to be keeping an eye on that. And hopefully it's not going to have a impact, but we're starting to see some residual impact already. The second one we're very, very concerned with because it would be devastating is Medicaid, and any cuts there, probably with most of the providers here, would be pretty significant. The average facility for behavioral health in Massachusetts is over 40%, Mass Health 44%. So any reduction there would be very, very harmful. So we're going to be watching all these things and hoping for the best, but already we're starting to see some serious concerns. Thank you.
Thank you, David, and please do keep us in mind as you continue to learn more and see some of these trends. Certainly, I think the questions about changes to the Medicaid program and the financing of the Medicaid program, are clearly under discussion and may be part of future budget reconciliation or other action around fiscal policy that can come later this year, and so certainly would have wide-ranging implications for our system and for our government. Chris Schuster, great to see you.
Great to see you too, and nice to see everyone back. If there ever was a need for this council, it's now, right? Because of what we're kind of facing. I've had a lot of discussions with our staff. This is really difficult on the frontline workers in that, every day they're hearing of a new change, and we've had to sort of say, unless something is issued as a law or an order, there's a difference between what you might hear, sort of rumor, or what may happen, as opposed to what's happening in the front lines. But there's a few things that I would just highlight. Have to support Dave in Medicaid cuts. We cannot take any more cuts in healthcare. Why? The labor costs are going up in double digits, and our reimbursement rate isn't going up as quick. And so it's really, really difficult for any one of our hospitals to take any kind of a cut. On behalf of my academic colleagues, I would have to bring up the NIH funding. What separates us, what is an economic engine in our healthcare community in Massachusetts really is what we do in research. And that's what keeps us cutting edge, and that would be devastating for our economy. The other thing I just would add is we've done a lot of work related to our waiver on health equity, on gender affirming care. Think about Children's Hospital. Emerson has a huge practice in gender affirming care. And many of us have changed our Epic and our Meditech systems to not just identify males, females, but what pronouns do you go by? Are you binary or you're not binary, so that we can have specialized care with our patients. And staff are really confused now by that. I've heard it's just male and female. How do we address people? That's really difficult because we've made so many strides in the last 4 years in the spirit of equity and equitable delivery of care. And for that just to be wiped out in one fell swoop is really difficult. And the last thing I'll just say is our staff are really concerned about coming into houses of worship and hospitals to, arrest people, basically. And in our community, the food pantries have reached out to us because the people that use them are down, and they've noticed that it's the immigrants and the migrant population. And food insecurity is a huge issue, one we don't think about all the time, but it really is impactful because of what we see here about immigration. So I think we as healthcare providers just worry about how this impacts people day to day. Will they get the food they need? Will they keep the appointments they need, especially, mental health and people with chronic diseases? So I think we have to follow this very closely and then, work together when something does become a law or a change in how we're going to address it together. I mean, we are Massachusetts, but we are part of the United States of America, and we have to work together on this. That's it.
Thank you, Chris, and I full-heartedly agree with your sentiments around and really part of my goal today was to begin this capacity of sharing information, and so that we can identify those areas where we can work together and collaborate and have where it makes sense common approaches. Chris, if I can ask you a question, you mentioned at the very beginning of your comments, around talking to the workforce and your employees at Emerson, and a sense of maybe daily confusion and disruption. What has been your message, to your team in terms of, how to process and navigate some of this?
I'll send you after this meeting the email that I'm sending out to our entire organization today, saying that we know it's a difficult time, and here are some guidelines for caring for patients, for questions you may have. We want them to get surfaced early. People are worried for their safety, what happens if, and we have a diverse population. We're very welcoming to that. And so we try to give assurance to staff that we'll remain open to caring for anyone, whoever you are and wherever you are on your health journey, and making sure that they know that Emerson is a safe place for them, and that we're going to continue that regardless of what happens and what changes. But I will send, out the memo to you so you can see how we're trying to actively address it. We have a lot of people who are upset. We've seen a 28% increase in access to our employee assistance program. And, the feedback we've gotten, while confidential, is that people are concerned about care delivery. Some people think, do I even want to work in this industry with all these changes? And so we just want to continue to affirm people that they're safe here, that our patients are safe here. We have 4 migrant hotels in our market. So we do see a lot of them through our ED and urgent care. And again, just making sure that they feel safe. I'm not sure that the first place ICE would come would be Concord, but nonetheless, we want to make sure our staff feels supported.
Thank you. And thank you for your leadership here and being proactive and communicating that. And if you don't mind sharing, would love to see how you and others are communicating and messaging with staff during this time.
Will do.
Barbara Spivak, great to see you. Welcome to the HPC Advisory Council. Would love to hear what you're tracking, what issues you're thinking about.
Thank you. For those who don't know me, I'm Barbara Spivak. I'm here representing the Mass Medical Society. I'm also a longstanding primary care doctor in one location in Watertown. I think that the Mass Medical Society is really going to reiterate what we're concerned about is what everybody else has been speaking about. I think that the 2 major concerns right now are the Medicaid cuts and the potential for NIH cuts. Recognizing that much of the healthcare in this state is organized around academic medical centers and systems that are organized around that. The estimate that I heard in Washington this week was that the state could lose $2 billion in funding. That will shut healthcare down. That's just an enormous amount of money. And we already have terrible access problems, not just in primary care, but in certain specialties. And people are really frantic about how they're going to continue to take care of patients with that level of cuts. I think the immigration and the reproductive health issues are very concerning. People are very concerned about the legal issues of prescribing medicines. We are we are an open state around abortion, and people are prescribing out of state. The legal liabilities and whether the protections that Massachusetts has put in place, will they be enough, are very, very concerning also. And I think, to be honest, physicians are well aware that we are very lucky to be living and practicing in Massachusetts, where everything is going to be done that's possible to really save the care that, for Medicaid, NIH, transgender care, abortion care, all of that, that we are living in a state that's going to do what it can to preserve healthcare. Thank you.
Thank you, and thank you to the Medical Society. And if there are, information that the Medical Society is sharing with members, or if receiving incoming questions and anything you can feel comfortable sharing with us, it is appreciated. I'm glad you mentioned the NIH funding piece, and I just wanted to highlight on this slide. We pulled some information from our Attorney General recent complaint detailing 219 organizations in Massachusetts received NIH funding to support over 5,700 projects. And I think the estimates of the potential loss in indirect funding, here it was $1 billion. I've seen $2 billion. I've seen $2.5 billion. And so regardless, a potential for a significant monetary impact for a key part of our economic and health infrastructure here in Massachusetts, is one of the, I think, if not the highest state on a per capita basis receiving NIH funding. Amy Rosenthal, would love to hear from you and what you're hearing at Healthcare for All, and what issues you're tracking most closely.
Thanks. And I was almost going to take my hand down because I think so many people have said this well, and so I'll try not to repeat what I heard from others. But I will say, we pretty quickly started to see a dip periodically on calls on the helpline, and also very different types of calls. One of our counselors on our Portuguese line just told us earlier this week she had 3 calls in one day from people just kind of incapacitated with fear about whether or not they should go to an appointment that they had. And so the fear is extremely real. We had a woman who was 7 months pregnant beg us to help her disenroll from health insurance coverage. So like that, the stories just kind of keep coming. I would say I know how much provider institutions are working so hard to figure out how to deal with protocols and dealing with issues if ICE were to arrive. I would just share, and a lot of our team is on a lot of like local community WhatsApp groups, and also talking to our community-based partners. The fear in the rumor mill is just so alive, and so there'll be posts that'll say something like, this institution is not going to protect us from ICE, like cancel appointments there. So it's kind of that extreme. And so while I do know from talking to people on this call that institutions are taking a lot of important steps to do everything they can to protect patients, I think somehow any opportunity that people are able to do to communicate that out to their patients, their community residents, et cetera, the more that's going to go to help folks. And I know everyone is trying to do their best. I just want to share like what we are hearing. 2 other things I would say, obviously the cuts to Medicaid are just terrifying, and the new budget resolution numbers that we're seeing are clearly deeply concerning. This is one of those like ask for forgiveness later. I'm just going to put out there that for those of you who are not familiar with the Coalition for Coverage and Care, which is led by Healthcare for All, the Blue Cross Blue Shield of Massachusetts Foundation. We are a coalition of about 100 groups that are working to do federal defense around access and affordability of health insurance coverage here in Massachusetts. So if anyone is interested in learning more, feel free to reach out to me, and we would welcome you to join our work. So.
Thank you, Amy. Thank you for sharing. And I, again, I think the Healthcare for All hotline is, a key place to get a pulse of what some of the issues that are bubbling up and the patients are facing, residents are concerned about. And so, I think it's always been valuable to be able to hear and understand what you're, hearing on those incoming calls. I just to ask you a little bit of a question. I mean, just how are you thinking about the role for Healthcare for All moving forward, with potential changes that could have implications for coverage, for the the connector exchange, and how are you kind of forecasting and thinking about the year?
Yeah, I mean, I think the first thing that we actually have control over right now is to try to do everything we can federally to try to prevent the cuts from happening, right? So that's kind of where we're directing our advocacy. And we know we have a delegation, fortunately, that's very supportive. However, they need the tools to be able to do the work that they need to do and that we want to be asking them to do in DC. So story collection is, in a conversation I had with a delegation with an office the other day, it was like, they must have asked me 5 times in a 20-minute call for stories. And so again, like, we're undertaking an effort to collect stories in a central bank for folks. Again, if anyone's interested, let us know. And so I think that that's our first line of defense. Then I think, if those are not able to be stopped, I think we're going to have to work very strategically and in a smart way to figure out how to protect as much as we can here in Massachusetts. And I think, if there's a worst case scenario, then those are going to be really tough times. And so I think we're just we keep saying we don't want to be paralyzed by all the incoming that's happening. So we're going to focus on what we can do and where we feel like we can have a voice, and that's directing it at this, supporting our delegation and making sure that they have what they need to try to fight off as many cuts as they can.
Thank you, Amy. Liz, great to see you. Would love to hear what you're hearing and thinking about.
It's great to see all of,
We can hear you.
Oh yeah, okay. It's great to see all of you. For those of you who don't know, my name is Liz Ogilvie. I live in Springfield, work across the state, very centered in Springfield. I think my voice is just community driven. And I want to say ditto to everything that's been said. And I've spent, sadly, a good amount of time in DC engaged in advocacy. January is historically, and early February, we're usually advocating for things like the Farm Bill. For those of you who don't know, it's like Where Food is Medicine is funded, so I can connect with where you are. We have a huge state infrastructure program that is Food is Medicine, the Healthy Incentives Program, and the patients that you all serve, it's everyone who has SNAP benefits receives an additional benefit in Massachusetts that allows them to buy produce at farm stands, farm stores, and directly on farms, or to be engaged in CSAs. It's one of the ways we've financed so many Food is Medicine programs across the community. Before the new administration started all that they started, this program, HIP, had been cut because of budget shortfalls. So embedded in what I have to say is also an ask from this body. That program went from federal funding. So you think about the money that comes directly to medical institutions, but you also think about all the funding that goes to other entities that are working very hard on health equity to either reduce ER visits. We're trying really hard to be good partners from the food system perspective. And our hands are tied not just at the federal level, but at the local level. For community-based organizations, farmers, any entity that gets federal funding, despite the executive orders being paused, half of our grants have been locked. So even if we had funds that were awarded, we can't access them. And some of those funds paid for car rides to medical appointments. And the immigrant situation, I personally know a woman who was picked up by ICE. Her daughter works in our farm program and is in our civic advocacy program. And she was picked up at a sausage making plant that she works at. We have no idea where she is, but everyone who knows her and the 4 other women who were picked up, none of their children are going to school. She is from Guatemala. Her husband's from Mexico. He's going to take the children and go home. I just want to put an identity around what you all are talking about. And the farming industry is going to fall completely apart, the produce farming industry, because I have dairy farmer friends who are telling me to put cows down in the last 2 weeks because they didn't have to come and run the milking machines. So everything you're talking about is going to be devastating. And we learned some things during COVID. We learned how to offer services better, more directly. We learned about telehealth. We didn't do it great in terms of an equity perspective, but we learned how to do it. Every single lesson that you learned in your institution, if you journal, I don't know how you track what you've learned, wake it up, because we are in for a long haul. I met with legislators from both sides of the aisle. I heard from 2 on the Ag Committee, which controls the Farm Bill, which controls all the USDA funding, that they don't expect SNAP to go completely away. They expect drastic cuts. And a Texas senator and a West Virginia senator told me, you should think about moving to a new state. Our state is particularly vulnerable because of the historic relationship that we've had with this administration. Our now governor, then attorney general, sued him 3 times. And this is an administration that's an aggressive, I would say, hit list, for lack of better language. And so I don't say that to cause panic, because you're absolutely right. What we need to do is be the bearers of calm. My ask for you is that you use your legislative relations, or even potentially think about sending a letter to the governor saying HIP needs to be turned back on. Our patients are being harmed. And your staff is being harmed because half of your frontline staff are themselves SNAP recipients, and then as a result, HIP recipients. Whatever resources you have to provide supports to those people now. We're looking at this from a head academic perspective, and your hearts and bodies need to get engaged yesterday around this. This is not a short-term thing. These lawsuits are going to have money tied up, and they're going to continue to cut and slash. And it's the fear factor that's as important as the actuality. You all said it incredibly well. I just wanted you to hear from somebody who's seeing it, living in it, having the healthcare clinics that we partner with to provide free farm shares calling me up saying, I'm going to have patients who are going to die, and thinking that USAID, when we're looking at that, that's over there. I have a friend who works in tuberculosis, and they haven't had drugs for nearly 2 weeks now. And she's from the US and fearful of a pandemic. So you're smarter than I am, better resourced than I am, better connected than I am, and you look like the people making these decisions. Those are all assets for you, and I need you to put them into play. So, David, I don't know what you need formally from me to ask that the HPC speak up specifically around HIP, but I'm making that ask. And so grateful for you giving me so much time.
No, thank you. And thank you for sharing that community perspective, as you said, and sharing a human face and a human story to what, even on this slide can feel sometimes, just a bunch of legal orders and directives, but the implications on people and residents and our systems, has a potential to be profound, and sounds like it already is. And then I also just want to appreciate and thank you for tying in the issues of food insecurity and the impacts on food systems, as it always relates to health and health and well-being. You know, I think there was a recent survey that I had seen, you know, a third of Massachusetts households experiencing food insecurity. Some of those numbers unfortunately have increased, and now to potentially be some of the supports being eroded. I think it's something we absolutely need to continue to track and understand, and to work together as a community to protect and try to collaborate on what we can do. So I appreciate your comments. Donna, it's great to hear, great to see you. Interested in what you're hearing and what you're tracking closely here.
Thank you, David. And I want to thank everybody who's spoken for all the work they're doing and their vigilance and advocacy. We're tracking a dozen different federal agencies that affect the lives of people who are at risk for or who live with behavioral health conditions. And we talked about healthcare, obviously, upon which folks are heavily dependent. And I'm very grateful to our Mass Health friends who are, you know, examining scenarios about what the impacts could be should they cut what are threatened as much as 25% cuts, which is over $4 billion here in Massachusetts. But we're also looking at HRSA with the focus in HRSA on the integration of behavioral health and primary care and services upon which our folks rely. The dissolution of the Department of Education. The Title I funds are very critical for kids, children and adolescents at risk in urban and rural communities. But the IDEA, Individuals with Disabilities Education Act, the Special Education Act, which is administered by the Department of Education, which is where any children with disabling behavioral health conditions or co-occurring behavioral health and intellectual and developmental disabilities would not just get education services, but are often getting supportive mental health services and disability supports, and often sometimes getting active treatment as part of their individual education plan. So we're worried about that. There is a move that's less talked about publicly, but behind Project 2025, the Manhattan Institute has called for the dissolution of SAMHSA. SAMHSA has the Mental Health and Substance Use Block Grant, among other grants, including those for certified community behavioral health clinics that would be put at risk by this. We've talked with the state, and they've received the notice of funding in this year because the federal year has already started for the current block grant. So the risk is greater for the future, but something again that people are tracking, because in a year when we're facing some cuts in the governor's budget in behavioral health, these federal resources are critically needed. HUD is another area. If you look at who is chronically homeless and the dependence of people who are chronically homeless for any relief from our state, which does a very good job. We all need to do more, but these federal programs are critical, and the pullback on these programs is challenging. And then the DOJ, a lot of the pending consent decrees that have been frozen at the DOJ, some of which have to do with police misconduct, disproportionately affect the people we represent, and chronically homeless people, who, by the way, the arrest rate for homeless people is 22.5 times higher than the arrest rate for the rest of us. A little appreciated fact, and 90+% of the people who are chronically homeless are people who live with mental health and substance use conditions. So these are all important services, Title 20 social services for kids, families, and adults. I'll stop there. Thank you.
No, thank you. And, certainly as we think about potential future changes, you mentioned SAMHSA, among other things, just encourage you to continue to reach out to us and see how we can be helpful.
Thank you.
I wondered if I could ask Tish or Steve, are there particular issues, Tish representing the teaching hospitals and thinking about perhaps the implications of some of the NIH funding? What are you hearing in terms of talking to your members? Is there information that you're currently collecting to try to understand some of these implications? I'm just not to call on you, but would love to hear if you have any thoughts to add.
Thanks, David. Steve, why don't you go ahead?
No, go ahead.
And I'll follow.
No,
Okay.
I'll follow up. Go ahead.
So David, just to talk briefly about the NIH cuts, COBIT joined a national organization, the AAMC, in a lawsuit in the same court and in collaboration with the attorney generals, in large part to extend the temporary restraining order nationwide. As you know, the AGO's lawsuit was limited to the 22 states that were on that lawsuit. And so we were successful in extending the temporary restraining order nationwide. We did get certification last night that the DOJ has indicated that the NIH and HHS are complying. Obviously, we need to verify that and pay attention to it. But for now, it's business as usual with respect to that. I will say the impacts are profound already. We are academic institutions where training and inspiring the next generation of physicians and scientists is a huge part of what we do. And so our leaders are navigating, trying to keep that pipeline encouraged and enthusiastic about their careers and their work, at the same time really dealing with an unprecedented level of worry. I want to underscore too, we are also extremely worried about Medicaid, which Amy had mentioned, and the loss of SNAP. Those are two big areas where we see potential funding cuts under the latest proposals coming out of Congress, directly hitting Medicaid, directly hitting nutrition benefits. And so we're worried about that and the impact that has on the patients we see. And then one other area that is always a worry is graduate medical education reimbursement. That reimbursement is important to us, but it's always vulnerable in these budget fights. And thank you to the HPC for your support for that, for Medicaid as well. But we're very worried that that's coming. And that obviously is yet another blow to academic medicine. And that goes for both our Medicare graduate medical education and children's graduate medical education, which would impact our pediatric providers. I'll stop there, Steve.
Thanks, David. Thanks, Tish. And thanks for your leadership on some of the NIH challenges that we face. I mean, David, you know how important research is for our Commonwealth and our economy. It's also incredibly important for patients. I mean, we all have friends or loved ones or know someone that's in a clinical trial of some sort that's supported by NIH funding. It's an enormous impact on the lives of the people that we serve. And it doesn't matter. It's interest rate, right? There's not just patients that are in clinical trials that are in Massachusetts. And I think we need to remember that. I'd say our members are very calm, as they always are. They're really good at dealing with challenges. They've been dealing with it now for the better part of 5 years. And when they see someone walk through the door in need of service, they see them as a patient. They don't see them as anything else, and they're treated accordingly. And we'll continue to do that as long as we can, regardless of what the challenges are that we face. As you know, we had challenges before. And so there are continuing to operate in a weakened, fragile system, and this makes it a little bit more complicated. You asked earlier kind of what we were doing in terms of interfacing with workers and directives. So we've created toolkits around immigration, make sure that everyone has the tools that they need when someone comes in, and they know what we are doing, what they're expected to doing, and how they interface with law enforcement. But it's important to note the interface with law enforcement now on a daily basis. And we've also created some patient-facing communication so patients can understand. To Michael's point at the top of the meeting, making sure that the worst case scenario would be the chilling of people seeking care that need it for them or a loved one. So we've communicated that out through our members and to the patients that we serve. The Medicaid funding is also very important. We've taken our work here, both on our waiver and being a leader in the country on that, as well as the important services that we provide for the Mass Health Program is critical. And any cuts to Medicaid would be a problem for the Commonwealth. In terms of NIH funding, the only other thing that I'll note is that there are 3 states that do an awful lot of research and incredible work, and they are North Carolina, Texas, and Ohio. And so there are many states around the country, red, blue, or purple, that rely on NIH funding to do important things for their economy and for the people that they serve. And we're partnering with them and trying to collaborate across the country. So although this challenge is it is a new one and a complicated one, the idea that we have all on this call collaboratively and collectively faced challenges before is not new, and I'm certain that we'll rise to the challenge once again.
Thank you, Steve. Thank you, Tish. Thank you both for your leadership and your message here. Reflecting both of your comments and other comments today, the work of associations is really important. It seems to me to be able to provide common information, to be able to collect strategies and toolkits, to be able to share across organizations that are often facing similar challenges, and how can we collectively work through these organizations to be able to push out as much information and support as possible. And so the work of all associations and healthcare, I think, is going to be really important as we move forward. And Steve, I of course appreciate your longer perspective here in terms of the last 5 years. And of course, it's not, I think, lost on many of us about how we as a community reacted and worked together in the pandemic, and really tried to find areas for collaboration and common solutions, and that ethos, that Massachusetts ethos, I think will only be more important moving forward. Any other advisory council? Laura, I think I just saw you.
Oh, thank you. Yeah, I didn't raise my hand, but thank
Okay.
you.
Please.
I know. I appreciate all the comments today, and I'm getting a lot of texts. People are just feeling very, very sad. So I thank people for sharing their perspectives. I think it's going to be, we don't always agree on everything here, but I think it's going to be more important than ever that we share information and work together where we can. And I think the other piece is, I think it's going to be really incredibly important that we not get ahead of the Healy administration and we take some direction from them. There are going to be a lot of things coming at us in healthcare, and we need to prioritize. And I really look to them for guidance as we move forward. And so I know my plans right now are looking to them, to the Division of Insurance and others for insight and a way forward on some of this, as well as Medicaid. But I think the Medicaid cuts are very troubling. We've done wonderfully in our state to cover people with huge advancements, and I think all of that's at risk. But it'll be important. I think we have shared goals of keeping our coverage gains and keeping Massachusetts the incredible leader it is in healthcare. So we'll do that together, hopefully.
Thank you, Laura. Any final thoughts that anyone would like to share on this topic? Liz, please.
David, I just have one quick thing,
Sure.
and this will make some uncomfortable, and just take a deep breath. If I can tell you, you can hear it. I have been in a clinical trial facilitated by Mount Sinai. I live with lupus nephritis, and I was informed day before yesterday that the pharmaceutical sponsor has decided to suspend phase 2 of the study based on the landscape and communications they've had from NIH. I did not intend to share it, but I want you to see what that looks like and hear what that looks like in my life. It means that a maintenance drug that I was on that was doing well, that I had to stop taking to get into this study 3 months ago, I now have to go wait a period of time before I can go back on it, and then hope that I have not had further deterioration while I put my hopes in this study. We don't know who our friends and neighbors and colleagues are who are being impacted immediately already by this, and I want you to know you know someone. And you know someone who spends every day of her life working to help meet the need of folks who don't have the resources, not financial, but just the ability to navigate and get myself into a study, and still working really hard to advocate for them, because I know there are people living with lupus and many other things just like I am. And I'm an optimistic and confident person, and I would just say, use your resources. And we don't have a moment to be in despair and worry. You are clinical leaders, you are organizational leaders, and as much as you can come up with immediate responses, you can set a tone, you can steady people. So steady yourselves so you can steady all the rest of us, because of a 15-year-old who has seen me, near death. And now I don't know what I've done to myself getting into this study, but I knew exactly what to do when I got this information. Other people in this study, who I've met some of them, don't have the capacities to get back into their nephrologist's office because they've been using this study as their care maintenance. And you know better than I do what, getting physicians is like. And so I'm worried about all of them. And I don't have time to be in a panic, nor do you. So, David, should I send you a letter asking for some support around HIP? We just need a letter from the Health Policy Commission that says this is deeply impacting our patients and our systems, because you are going to see more need. You're going to see more ER visits. You're going to see more people coming in, not being diet compliant, and all of that. So a letter, a call, a legislator is going to take your call when you tell them where you're calling from and say, we are keeping our eye on what's happening federally, but locally, here's what I need you to do today that could result in a supplemental budget amendment next month. Thank you so much. Everyone be well and take good care of yourselves. I don't want to act as if you're not being impacted by this. Go outside, turn your face to the sun when it's out, and be grateful for the places that you hold and the abilities that you have to not just sit in a panic in your living room and wonder about every single knock that's coming on your door. And we do have some community resources, and David, I'll forward those to you, like Know Your Rights in many languages, things that you can send out that hopefully these organizational leaders can send down staff. Again, wishing you all good health and strength.
Thank you, Liz, and thank you for sharing your story here. You don't need to send me a letter. We can consider the request lodged, and I will follow up with you on that topic. Thank you. Barbara, please.
Just Liz, thank you for sharing. And what it says to me is it also reminds me of all of the programs for transgender adolescents, where they were literally on the way to get their treatment and be told, don't come in because we're closing our program. And I can't imagine the psychological and physical trauma that's causing those brave transgender adolescents. I can't imagine how much it took for them to go through the transition and then to be told that their government is forcing their caregivers to shut down. And I think it's that kind of personalization that we just all need to keep in mind. And it's hard for the physicians because also to remember, and understandably, the institutions are making those decisions, and the caregivers are the ones who have to follow and give that message. And I'm not blaming the institutions. They can't afford to lose funding either for the rest of their programs. So we're all caught in this terrible nightmare. But thank you for sharing.
Thank you. And thank you all for the messages of support. I will just share just from, the Health Policy Commission standpoint. We have, made an intentional effort to embed health equity and the concepts of a health equity lens into all of our work. We have a equity in everything approach to our research, to our investment programs, to our policies and initiatives, to our review of the healthcare market and system here in Massachusetts. We have investment programs and grants that we're launching right now focused on reducing disparities in maternal health morbidity. And we are not backing away from any of that. That is core to our values as an organization. And I think core to the values of the Commonwealth. So we are moving forward on all of that work and not taking a step back. I will also share just, one implication that has come for us in our work that wasn't mentioned here today. We have a pretty robust, research team here that really mines data and information from so many different sources to do our work and to understand the performance of our healthcare system and patient care in Massachusetts. And much of that data we do get from the federal government. And unfortunately and concerningly, we've seen some of that important information at the CDC and other CMS has been removed from some of the websites or disabled. There is some census downloads that have been disabled, and some of the data and information that we would particularly be able to get and download in terms of flat files is being changed. So one of the small things that we have done here is our research team has been going on to many of the federal websites and downloading as much of the data and information that we can, going back into the internet time machine to be able to extract and protect this data and information. And any compromise of this important health information and data does compromise the work of the organization. So we're doing as much as we can to try to download and protect that important federal data and information. Thank you all for that conversation and discussion, and I think more to obviously want to continue to be in touch and communicate as we move forward throughout the year. With just about 13 minutes left in this meeting today, I just will quickly share, I think, some important and exciting updates, a little bit of a pivot in agenda here. But I think reflecting Massachusetts's leadership on health policy and on proactively addressing some of the challenges in our healthcare system, we were very pleased to see that there was legislative action that was taken at the end of calendar year 2024 in advancing two significant bills. One focused on pharmaceutical access, costs, and transparency, which includes provisions around an enhanced transparency of pharmaceutical trends. It establishes a new Office of Pharmaceutical Policy and Analysis within the Health Policy Commission to really act as a hub of expertise, both for state governments, but also beyond in terms of thinking about pharmaceutical access questions, affordability questions, trends in innovation that we see in this important sector. This is obviously an important sector to Massachusetts economy and to innovations in patient care. It is also an area where there has been high growth in spending in recent years. This has been an area that has been one of our primary drivers of healthcare spending. And so having this increased transparency and accountability within the Health Policy Commission is going to be, I think, really valuable, important as we think about this particular part of our healthcare spend and its relationship to medical spend writ large. Not specific to the Health Policy Commission, but also to note here that this legislation also includes important patient protections and caps on out-of-pocket costs for certain drugs to treat common chronic conditions. And this will have, I think, a real positive impact on patient access to these important pharmaceuticals. The other bill that was passed is an act enhancing the market review process. And this law really focuses on bolstering and strengthening some of the state's oversight of changes in our healthcare market. In many ways, this law is reflective of the experience that this community went through last year with the bankruptcy and dissolution of Steward Health Care, and continued questions about the impact and role of private equity in healthcare and healthcare providers and organizations in Massachusetts. Importantly, this law does include provisions that would expand the Health Policy Commission's role in tracking, monitoring, and reviewing provider changes like private equity investment and ownership of healthcare providers, like things such as a sale of significant assets, such as a real estate, or organizations entering into real estate leaseback arrangements. Clearly, these were some of the activities that Steward Health Care was engaged in that ultimately contributed to that bankruptcy, and will be important for the state and the public to understand these trends and the implications of these trends moving forward. The bill also strengthens the state government's ongoing ability to make sure that all organizations are providing the right type of financial information and data information necessary for the monitoring that we do to protect patients and to protect patient access to care. And one final thing I'll just mention here that I do hope to return to this group to talk more in depth about is a new Office of Health Resource Planning, which is established within the Health Policy Commission. And if we can maybe just advance to that slide that has the summary of the Office of Health Resource Planning. I think the one right before this one. So this is, I think, an important and exciting provision within this law that really reestablishes and reinvigorates a state health planning process to be able to understand the anticipated needs for our patients, for our healthcare providers, and our facilities, and what those needs are now and what they will be into the future, to really help inform state policy action, to inform market behavior, so that we're continuing to build and advance a healthcare system that is meeting the needs of patients across communities, and that the supply and distribution of our services is really matching those needs. This has been an effort that the state had done in the past, back in the 80s and early 90s. Ultimately, this was discontinued in favor of a more a private market approach. But here we see an opportunity to use data, research, and the collaboration with this community to really be able to identify what are our priorities in terms of building a healthcare system and maintaining that healthcare system, and potentially avoiding closure of essential services and high-value services. So this is a new office within the HPC. I expect that much of this work will be done in collaboration and communication with organizations across the Commonwealth. And I guess I'll just end with a point to say we really look forward to engaging this advisory council on this important work and how we can leverage this work to continue to strengthen our system. So just wanted to give you a little bit of that overview. I know we're out of time, but as I said, look forward to continuing to seek your counsel as we implement these important new provisions. Finally, I want to extend an invitation to all of you. Next month, we are holding our annual hearing on the healthcare cost growth benchmark. This is an annual process that we do in coordination with the Joint Committee on Healthcare Financing. And at this hearing, we do solicit input and testimony from any interested organization to help inform the Health Policy Commission Board's decision about where to establish the healthcare cost growth benchmark, in this case for calendar year 2026. So this will be Thursday, March 13th at noon in the State House in person. As I said, encourage any organization here to come and provide live testimony, or we welcome written testimony as well. So an important part of our annual process, and looking forward to that engagement next month. That is all that I had for you today. There is so much important work that we're going to be leading and working on this calendar year. I would be remiss without finally just saying something about the fact that there is a really exciting new primary care access task force, which was established in this legislation as well. That will be co-chaired by the Health Policy Commission and the Executive Office of Health and Human Services, and has 23 other members representing a wide spectrum of interested organizations and primary care experts, and really looking forward to launching this work and to moving with urgency around policy recommendations and policy solutions to strengthen and stabilize our primary care system in Massachusetts. So again, more to come on this one, and look forward to hearing from all of you about how we can best leverage this task force to make a real positive difference in this area where there is a tremendous need. So that is all I have for you. Thank you so much. Happy to take any final questions or comments. I know I kind of ran through some of that additional information. We do expect to have another meeting of this advisory council in a few months. I think we're targeting May. Is that right, Colleen?
Yes, May 15th is the target date for the next meeting of the advisory council.
Would that be at the same time,
Yes,
12 to 1:30?
same time, same place. Great.
We will follow up with all of you on information that about that. And thank you for sharing your information and perspectives today. I thought this was a really important conversation, and look forward to a year of good work ahead. So thank you all. Thanks all the members.
Thanks, everyone.
Thank you.